Live. So I just want to welcome everybody back to our live streams. Remember, we have these live streams every Monday. We have them from about 5 o'clock to about 5:30. As always, I'm Dr. Sean Hashmi. I am a board certified nephrologist. I'm also an obesity medicine doc. This is Self Principle. Self stands for sleep, exercise, love, and food. And I bring you new studies that are going to be informative for every aspect of your life, whether that's kidney health, whether that's nutrition, whether that's longevity, whether that's just overall health you're trying to improve. So, with that, let's go ahead and dive into today's three topics. So, the first topic is very interesting. It's going to talk about these new weight loss drugs called GLP-1, specifically semaglutide, which goes by the name of Ozempic, also goes by the name of Wegovy. We're going to talk about a very interesting study that's talking about the role of semaglutide and how it impacts your taste buds. Then we're going to get into a really interesting study that talks about early fasting. Remember, we've talked about intermittent fasting, and we've shown that intermittent fasting versus calorie restriction isn't that great. But fasting is amazing if you know how to do it the right way and you understand the studies behind it. So that's why we're going to talk about fasting and what happens to specifically your blood sugars and why it's so important to be able to do it. And the last one, which is important for men, because this is a topic we don't talk about enough, is low testosterone and specifically the fear of heart disease and what is the latest data on whether it's safe or not safe. So those are the three topics. Let's dive into the first topic, which I thought was absolutely fascinating, and that has to do with semaglutide, which is Ozempic and Wegovy, and taste sensitivity. Now, this is going to end up applying to the other weight loss drugs, to the other GLP-1s that are out there, things like liraglutide, which is Victoza and Saxenda as well. So the study that I'm presenting is actually presented at the Endocrine Society's annual meeting. This is for 2024. It's a very small trial. They recruited about 30 women. And what they were doing was they were giving them 1 milligram of semaglutide, Ozempic or Wegovy, or they were giving them essentially a sugar pill. And so when I say sugar pill, I'm just saying placebo. I use that term. It's not really a sugar pill. So let me make sure we don't confuse those two items. But the big of the study is important to understand so that you get an idea of does it apply to you or not. So at baseline, their average age was about in the mid 30s. Their body mass index, remember that's not the best measure, but it's important to understand what it is. So their BMI was 36 on average, and their weight was about 100 kilos. Remember, converting that into pounds is multiplying that by 2.2, or that would be 220. Now, all the women had a pre-existing diagnosis of PCOS, which is polycystic ovarian syndrome, and excluded or they kept out of the study people who had diabetes, pancreatitis, gallbladder disease, smoking, etc. So what happened was they either randomized them to semaglutide or they went through the essentially placebo arm and they raised the dose up for the first 4 weeks. They got them up to 1 milligram. So remember, it's 0.25, then it's zero point 0.5, then it's 1 milligram, and they kept them there for 12 weeks. And at the end of 16 weeks, they stopped the study. So here's where it becomes really interesting. What did they find in this study and why should you care? Well, it turns out when you have excess weight, what happens is your ability to taste foods that are either high in salt, high in sugar, high in fat, all of those receptors, remember we have four basic tastes: sweet, sour, salty, and bitter. And all four of those tastes get dulled when we have excess weight. So what happens is when they gave these patients semaglutide, their sensitivity for these tastes increased. So if you're watching this, you're wondering, well, why should I care? The reason you care is because when you lose weight, what ends up happening is your ability to enjoy food at that level gets better. Otherwise, when you eat it, it doesn't have that same satisfaction. So you keep on craving more and more, hoping to satisfy your sweet tooth or your sour tooth or your salty tooth or your bitter tooth, whatever it is, that taste that you're going after, you end up consuming more and more food trying to make up for that. So the reason this is interesting is these medications, the GLP-1s, actually improve the taste sensitivity. And so they didn't just stop at subjectively asking these people if you had better taste. They also did a number of things. The first thing they did was they used 16 taste strips. And what they did was they were basically laced with those four types of taste to see how the participants would respond. And then in addition to that, they actually did RNA sequencing. This is where it becomes really interesting. They did RNA sequencing of tongue tissue for four specific genes. Now, these genes are important because these are the ones that are primarily responsible for things like taste, your taste bud development, being able to differentiate between sweet, sour, salty, bitter, and because of that, what was very fascinating was that GLP-1s increase the expression of these tastes. But it doesn't stop there. The next part that becomes even more fascinating is they did an MRI scan to measure brain activity after they basically had these people who were on semaglutide, after they gave them a sweet solution or something else that was there. And what they found with these MRI scans was that the people who were on these GLP-1 medications, they had very significant parts of their brain light up, specifically the area of the brain called the angular gyrus of the parietal cortex. The reason this matters is because that's the part of the brain that's responsible for essentially willpower, the idea of comprehension and reasoning. So, what's fascinating about this stuff is that the participants who were on GLPs, if you had them see foods that were rich in sugar, foods that were rich in fat or bitter or sour, all those high calorie foods, what they saw in their MRIs was the part of the brain that would crave those foods, it lit up less than the parts of the brain that would normally light up. And the folks that weren't on GLP-1s, their brains were lighting up like crazy. So, how do you summarize all this data? Bottom line is this: these drugs, there's a number of new discoveries. We're finding out more and more that they do affect so many different parts of our brain. They're changing how we're able to sense taste. So they're changing our ability to be able to taste the four main tastes we have, which is sweet, sour, salty, bitter. Why is that important? Because what patients say when they're on these drugs is that they don't feel that food noise, the constant noise in your head that says, I gotta eat, I gotta eat. They don't have that noise. Now, don't forget that even though there's all this information about these drugs in terms of how good they are, there's a number of side effects that are very dangerous. We've talked about the risk of stomach blockage, the small chance of thyroid cancer, the part about affecting your mood, potentially causing depression and even suicidal thoughts, pancreatitis. And so there's pros and cons, and that's why you got to make sure you talk to your doctor. It becomes really important to make sure those conversations are happening before you start, and you have a game plan on how long you're going to do it, how you're going to get off of it, and don't become addicted to the drug. If you go from being addicted to food to now addicted to the drug, you've just replaced one bad habit with another bad habit. So even though this is a fascinating study, please keep in mind that these drugs aren't necessarily the best options. You still need to have lifestyle. You got to have your life and you got to add some style to it. And you got to make sure you do those things. So that's the first study. The next study we're going to get into is early time restricted eating and what happens to your sugar levels. But before we do, let me check the chat because I see there's a tremendous amount of questions coming in. So let me answer some of these questions and then we'll go to study number two. Let's see. Uh, oh gosh, I can't say your YouTube name correctly, but 65-year-old blood pressure is always 100 over 60, not diabetic. Albumin creatinine ratio is about 98. I stopped taking an SGLT2 and losartan because the diastolic is 60 and sometimes the blood pressure drops to 90 over 60, 80 over 50. Please advise. So remember, the most important thing that this gentleman is asking or this gentlewoman is asking is that the medications that this person is on is dropping their blood pressure. And so the question is, what should they do? So keep in mind that the dosages that you just stated for losartan 50 milligrams, we can do losartan 25 milligrams. We can do losartan 12.5 milligrams. For SGLT2 inhibitors, we can back off. Remember, SGLT2 inhibitors like the dapagliflozin and empagliflozin, those are making you pee out sugar. So if there's a concern, not a big deal, we can fix that. So in other words, you don't have to go from being on them to stopping them. You still want to lower the protein in the urine. How do you do that? You can focus on blood pressure, which yours is already low. You can focus on weight. If your weight is high, you want to focus on that. And then your sugars. If your sugars are high, you want to focus on those. Let's see, Din asked the question from Toronto, Canada. Welcome, Din, as always. Why the blood pressure readings are different at every measurement? Because what happens is we are breathing, we are living beings. So if you check your blood pressure a few different times, you're going to find that yes, your numbers are going to be different just because of the fact that you're looking at it from did you move? Are you sitting? What's the heart doing in response to that? So, what you're looking for is what's your trend looking like? What's the average of several measurements? And if those measurements are running higher, 130s, 140s, 150s as a top number, then we definitely want to make sure we intervene. Just remember, don't worry about the different readings. And when you see that they're different by 20 to 50 points at times, then that means either the cuff placement is off, the cuff is too tight, the other time was too loose, you had just done activity, you were sitting, standing too fast. All of those little things we don't think about. Maybe you didn't go pee the first time, so your bladder was full, maybe your legs were crossed, maybe you're not sitting in a chair with your back straight. All those things can matter. So, in other words, once again, be careful about all those little things that can make an impact. But if those numbers are generally running higher, talk to your doctor. What's great is when patients bring me their blood pressure logs, it really helps me to be able to make better changes for them. All right, let's see. Carolyn said, same question, different readings happening. So yes, the exact thing as far as that goes. Holly asked the question, prorenal plus D, is it good to take for the kidneys? So in general, Holly, what we tell patients with kidney disease is we tell them to take a B complex. And the idea behind a B complex is because it's water soluble and patients with kidney disease, because of dietary restrictions, they can get low on it. And vitamin D, most of our patients, including myself, we all tend to run low on vitamin D. So vitamin D is good. So prorenal plus D is just really, really expensive for what you're getting. So no knock on that. There's other versions of that in terms of nephrovite and dialabide and all sorts of vites that you can do. But just look for essentially the Bs. There's a little tiny bit of C in there. And of course, they'll have vitamin D in there. The other things is to make sure that you're getting omega 3s. There's some fascinating data on how omega 3s plays such an important role. Forget about the controversial heart disease aspect in terms of brain health, in terms of mood. So all of us should be taking some type of omega 3s. And remember, animals don't make omega 3s. The fish are getting it from the algae. So you can take algal based omega 3 if you're plant based. If you're not, do whatever works best for you. All right, let's go into the second study. Then we'll come back to the questions, and same thing with folks on Instagram. If you guys have any questions, feel free to ask away, no problem. And for the YouTube guys, feel free to ask any questions that you guys might have. So the next study is we talk about time restricted eating. Now, intermittent fasting, time restricted eating is just one type of it, but intermittent fasting is really a fascinating phenomenon. The reason it's so interesting is because of the fact that people mistakenly misunderstand it all the time. Some people say, look, it doesn't work because the study showed the weight loss between cutting calories and doing fasting was the same. So therefore, there's no improvement. That's actually not correct. In fact, early time restricted eating has studies that show it's better weight loss than just cutting calories. But when you do fasting, the benefits are tremendous. It helps with inflammation, it helps with your gut microbiome. There are so many benefits overall. So, this is the TRIO study. And the reason this is so important is because it talks about what happens with just doing early time restricted eating for just 1 week. So, what happened? This was a randomized 6-day isocaloric, which means the calorie amount was the same in the control arm and the treatment arm. And what they were looking for was comparing early time restricted feeding, which they defined as eating between 8 a.m. to 4 p.m., and 80% of their calories were consumed before 1 p.m. So once again, between 8 to 4 is where they ate all their food, but 80% of what they ate was before 1 o'clock. So essentially, it's almost like going from 8 a.m. to 1 p.m. And the other group was able to eat all day, but both groups ate exactly the same amount of calories. So the question is what did they find? By the way, the BMI of these patients was average was about 37. They were A1Cs of about 5.8, so in the pre-diabetes category. So here's what they found. The most important and the most interesting thing was that just doing one single week of early time restricted eating, what it did was it reduced the fluctuations in blood sugar levels. Remember, when it comes to diabetes and the damage that sugars are doing, the biggest damage happens when your sugars are all over the place, the highs and the lows that are overwhelming the blood vessels, that are overwhelming the organs. You're trying to get slow and steady progress. And so to get that slow and steady progress, it's fascinating that just a little bit of fasting, eating your calories earlier in the day between an 8 hour window, that's all they did for 1 week, just 1 week was able to reduce the fluctuation. The medical terminology for that is mean amplitude of glycemic excursion or MAGE. But that's just technical. The important part of this is that these simple things like time restricted eating, which is a form of intermittent fasting, you can do quite simply. Now, of course, if you're somebody who's an insulin dependent diabetic, you can't do this. If you're pregnant, you can't do this. If you're elderly, you can't do this. God forbid, if you have cancer, you should definitely not do this. So just because there's one study that talks about fasting, it doesn't mean you should go out and do it. It just means that this is to add to your fund of knowledge so you guys start to understand how powerful this stuff can be, where if you just start to add a little bit of fasting in your daily regimen, you can get some really incredible results. All right, let's go to the comments and let's answer some more questions. Holly said hello. Donato said hello. Hi, guys. Nice to see you guys back. Let's see. Chatting with Allison, I think my blood pressure goes too low when I take losartan, which will be good for my kidneys. So, no. Remember, losartan is trying to reduce the blood pressure, not the blood pressure, but the intraglomerular pressure on your kidneys. Now, if you reduce it too much, then your kidneys aren't getting enough blood, so they're starving. So, in other words, losartan could be your best friend, but if you take the wrong dose, then it can be something completely different where it can hurt your kidneys. This is why working with your doctor is so important to understand. All right, let's see. Din said, is it safe to take Ozempic and CKD3? So, Din, the answer is yes, we do give it in CKD3, CKD4, CKD5, and even dialysis. A caveat to that is the side effects get progressively worse as you have worsening kidney function. So my dialysis patients, who some of them unfortunately absolutely need drugs like Ozempic to be able to lose the weight so we can protect them from all sorts of bad outcomes. Those patients, their side effects can be quite severe, so we have to be very, very careful. All right, let's see. Red meat intake seems to be a big problem in think it's NZ is New Zealand for kidney and heart disease. So, this is an interesting question because red meat, the biggest thing about that and kidneys is the acid load that we talk about. And we're trying to reduce the acid on the kidneys. The less acid you have in your body, the longer your organs will last. So the less acid that you have, the longer your kidneys will last. That's why the goal is always how can we less the pressure on top of our kidneys? All right, let's do one more. Casey said, can you explain nocturia, which is getting up and peeing a lot at night? What is normal for getting up and at night to use the bathroom 1 to 2 times? So Casey, first, I'm so sorry that you're going through it. When we're younger, basically sleeping throughout the night is considered normal. In terms of what's considered normal, that's tricky because you also have to think about what are your options. So if it's interfering with your quality of sleep, 1 to 2 times certainly will. If that's the case, then you want to look at what are the treatment options. For example, there's alpha blockers. Fluoxetine is a typical name, and there's ones that we use as well. But if you talk to your urologist, they can help you come up with a plan. Surgery is the last thing that we try to go after only because of the fact that there can be significant side effects. So if you can use medications, that makes a difference. The other thing is 4 hours before you go to bed, don't drink any liquids. That's going to be very important. I know that's hard, but 4 hours before you go to bed, try not to drink any liquids because that will help to reduce the urine that you end up having in the middle of the night. Okay, so let's talk about now the next part, the third and final study for tonight. And that study is about low testosterone, specifically affecting men, and why do we need to be careful about it and why we need to treat it. The reason is a lot of male patients, they don't want to talk about this topic. This is one of those taboo topics that we're not talking about people who are trying to be bodybuilders and they're taking all sorts of stuff. We're talking about people who actually have low testosterone, but they're not asking for help. So, what are things? For example, they can have inability to want to do stuff. They're tired all the time. Their memory is really bad. They might just feel like, of course, sexual dysfunction is the main symptom people talk about, but things like motivation, inability to concentrate, reduced body hair or gynecomastia, which is the breast enlargement that people can see. They can see their muscle mass is very low, but more important than that, they can start to have low bone mass. And low bone mass in men and women becomes a very big deal. So if you have low testosterone, the question is, should you be getting replacement? Not to get some crazy high level to be a bodybuilder, but just to bring it back to normal level. And so the danger has always been is, well, what's the risk of testosterone and heart disease? So let me present another study. This is an important one, was presented in 2023 in the New England Journal of Medicine. It's a well-designed study. It's multi-center. That's really important because that adds weight to the study. It's double-blind, so neither the participant nor the experimenters know who's getting what. It's a non-inferiority trial. So in other words, they're not trying to show one is better than the other. What they're trying to show is that neither one is worse than the other. They had 5,200 men ages 45 to 80 who had already very high risk of heart disease. So they had all sorts of risk factors that were already present, and their two fasting testosterone levels. So they did two of them to make sure were less than 300. Now, these patients on average, they had an average age of about 63. 80% of them were white, 17% were black. 50% had pre-existing cardiovascular disease. This becomes very important because this adds to the weight of the study. And so, in other words, in these patients, these are really high risk patients. So, if they're going to have heart disease and bad outcomes, this is how you're going to be able to see. So they randomly assign the patient to either get the transdermal, which just comes in a patch, or it can be a gel of 1.62% testosterone gel. This is the prescription that's given by your physician not what they're trying to sell in all sorts of shady websites. And the goal was to once again keep the testosterone in the normal range between 350 and 750 nanograms per deciliter. So the study lasted 22 months, but then after that, they did a follow-up of 33 months. So in other words, this is a really long-term study. And what they were looking for was the primary endpoint was just a safety thing. Did they have a cardiovascular event? And that's what they were looking for. So what they found was that the cardiovascular event occurred in 7% in the testosterone group and 7.3% in the placebo group. In other words, there's no difference between the placebo group or getting the testosterone. And this matters because this is a well designed study in a very high risk group. But not all things are rosy. There was a slightly higher risk with testosterone of getting a heart arrhythmia. So in the testosterone arm was 3.5%, but in the placebo arm was 2.4%. It's not that different, but you want to know that in the testosterone arm, it was slightly higher. There was a slightly higher risk of acute kidney injury, 2.3% in the treatment arm, 1.5% in the control arm. And then there was a small chance of pulmonary embolism or a clot in the lungs, and that was 0.9% in the treatment arm versus 0.5% in the control arm. Now, the reason this study is so important is because those patients who were in the treatment arm, they felt better, their energy was better, their mood was better, their quality of life was better. And so this study is not saying you should all go out and go on testosterone replacement therapy. What it's saying is that if you're suffering from it, it's an important conversation between you and your doctor to have, only because of the fact that a lot of men suffer in silence. Now, the other thing people worry about is, oh, is it going to increase the risk of prostate cancer for me? And the answer is no. They did not see an increased risk of prostate cancer. The PSA level, the prostate specific antigen levels, did go up, but other than that, there was no risk for prostate cancer. So then people ask the question, well, what about in kidney disease patients? The answer is in kidney disease patients, the same thing applies. So there's a study that was published back in 2022 in the journal. And what they were able to show was that taking patients who had significant chronic kidney disease, stage 3, stage 4, what they found was that essentially at 3 months, their free testosterone, their total testosterone went up, they felt better, and it did not affect the patients on dialysis, for example. There wasn't an impact in terms of fluid, in terms of anything else happening. So those things become important in that for our patients on dialysis who often have depression, often have a lack of desire to do anything, if on top of everything they are suffering from low testosterone, then this becomes an area that we can definitely help. All right, let's go back to the questions and answer a few more questions for you guys. Let's see. Karen said, good evening, Dr. Hashmi. Hope you're well. Thank you so much, Karen. I am well, except for my finger. I got back into jiu-jitsu. You know, I'm going to turn 50 this year. And boy, oh boy, these like 18-year-old kids, they're like so strong. I can't remember if I was that strong at age 18, but these kids are really strong in jiu-jitsu. Oh man, it really beats you up a little bit. So that's what this is all about. I'm always having injuries, some kind, but it keeps me fit, keeps me healthy, and that's why I like it. Let's see. I believe it's Yasua said, are psychedelics beneficial for healing trauma? You know, that's a really interesting question. I don't have enough experience to answer that question. The few studies I've read are mixed, so I would hate to say something that I don't know enough about. But I'll definitely do some research. I'll get back to you. Casey asked the question, is there a connection between CKD and thyroid, particularly hypothyroidism? Yes, there is. The only thing is what we don't know is it bidirectional? CKD leads to hypothyroid and hypothyroid leads to CKD, or is it one way? That's the only part. There's a very good possibility that it is bidirectional. MW said, hi, Dr. Hashmi. Hi, MW. Um, let's see. Leah said, what is a normal blood pressure for someone with a you mean a fistula? So once again, if you have a fistula, and I'm assuming that's what you meant to write, which is a dialysis access, if you have that, then we're still aiming for a healthy blood pressure to get it down to less than 130 as the top number, less than 80 as the bottom number. Chatting with Alice said, my zinc was low. Should people with CKD take a low dose of zinc? You'll always find that some of the kidney vitamins, they actually have a low amount of zinc in them. And once again, this is where your renal practitioner will be very important to make sure you're there. How much protein should a 145 kilo stage 3 patient eat? So, in other words, if you have chronic kidney disease stage 3, so remember, we talk about zero point 0.6 to zero point 0.8 grams per kilogram per day of preferably plant-based proteins. Now, if you're doing that, that's a low protein diet. So you got to make sure you are doing resistance training. Otherwise, it becomes easy to be able to get into trouble. And then the question was, what about water? How much water should you drink? Well, this is a really difficult question. In general, there aren't really straightforward answers to this. And if you're older, you can't rely on thirst because of the fact that your thirst will always deceive you. If you have kidney disease, you want water, so that becomes tricky. So in other words, this is where we need to be able to talk to your physician. We need to examine you and say, that's why I just can't say 2 liters a day would be good because that's not an appropriate answer without actually looking for the patient and knowing what's going on. And again said, is it safe to take supplements to reduce side effects of prednisone steroids like one from Dr. Megan Mutinized Zone? I don't know what that is, but unfortunately, when you're on prednisone, there isn't a lot of supplements that are going to do anything to reverse the effects. We try to use the lowest dose. We want to make sure that because it's breaking down your muscle, you are doing resistance training, you're watching your sugars, you're watching your intake, making sure your diet is healthy. The time is 5:32 now. I'm going to go rush over to go see my daughters train. As you guys know, they're doing jiu-jitsu, they're doing wrestling. They're going to get ready for a big competition in Virginia, so we'll be flying up there in December. So now it's time for them to really have a goal and see how far they can push themselves. But once again, I just want to thank you guys so much. I know you guys got plenty of other things you can do with your time. Thank you so much for joining today. I hope you guys got something out of this. And once again, the message is always the same, which is at the end of the day, everything that's going on in the world today, just please, just try to be kind. A little bit of kindness can change everyone's life. And it's such a beautiful thing. So take that message. Please take it to heart. And if you want to support this, just share it, spread the word. And I really appreciate you guys. I will see you next Monday at 5 p.m. to 5:30 p.m. Pacific Central Time. Thanks, everyone. Take care. God bless. And I'll